Hi, my name's Ted O'Connell, one of the authors of USMLE Step 3 Secrets. This is Case 4 in our CCS Cases video series from USMLE Step 3 Secrets. Please take a look at medicalschoolvideos.com for additional videos and like us on Facebook. Let's get started with this case. History of the present illness. A 19-year-old G1 P0 at 38 weeks gestation presents to the emergency room complaining of intermittent blurry vision and frontal headache that has not responded to acetaminophen. The headache has been present for 4 hours and is gradually worsening. The pregnancy has been uncomplicated to this point, and she has had regular prenatal care. She denies abdominal pain, contractions, loss of fluids, or vaginal bleeding. She takes a prenatal vitamin, but otherwise takes no medications. Vital signs: temperature is 36.6 degrees Celsius, pulse 91, blood pressure 165 over 100, respiratory rate 19. Additional history: there's no past medical history and no tobacco, drug, or alcohol use. What is a differential diagnosis? The differential diagnosis includes pregnancy-induced hypertension, also known as gestational hypertension, chronic hypertension, preeclampsia, and HELP syndrome. What components of the physical exam do you perform? Components of the physical exam that should be performed include general appearance, skin, HEENT, cardiovascular, lungs, abdomen, genitalia, extremities, and neuropsych exams. The physical exam findings: general, patient is in no acute distress. HEENT, within normal limits. Cardiovascular and lungs are within normal limits. Abdomen reveals a fundal height of 38 centimeters and is non-tender. Genitalia reveals a cervix that is soft and dilated to 4 centimeters. Is 60% effaced with a fetal station of -1. There is no pooling of fluids, and the presentation is cephalic. Extremities reveal 1+ lower extremity edema, and the neuropsych exam is within normal limits. What are your initial orders? Initial orders should include pulse oximetry, blood pressure and cardiac monitoring, CBC, Chem 8, PT, PTT, LFTs, uric acid, LDH, type and screen, urinalysis, a 24-hour urine protein, measurement of urine output, fetal ultrasound, a fetal monitor, magnesium sulfate intravenously, labetalol intravenously, and consult obstetrics. Advance the clock. O2 saturation is 100% on room air. Repeat vital signs reveals a blood pressure of 128 over 80. Blood type is O positive. Urinalysis reveals 2+ protein. Labs are otherwise within normal limits, and the patient's symptoms have greatly improved. What are your follow-up actions? Admit the patient to the inpatient unit, induce labor with either oxytocin or misoprostol, and provide counseling. Advance the clock, and the case ends. What are the critical actions in this case? Critical actions include a genital exam, a neuro exam, urinalysis, urine output monitoring, fetal monitoring, magnesium IV, and consulting obstetrics. Now let's discuss this case. Any gravid woman with symptoms concerning for preeclampsia, and these symptoms include headache, blurry vision, right upper quadrant abdominal pain, oliguria, and edema, should be promptly evaluated for hypertension, proteinuria, thrombocytopenia, elevated liver enzymes, and hemolysis using an LDH and uric acid. Preeclampsia is defined by a blood pressure greater than 140/90 with proteinuria. Blood pressure greater than 160/110 or the presence of symptoms is sufficient for the diagnosis of severe preeclampsia. Treatment includes seizure prophylaxis using magnesium and blood pressure control with labetalol or hydralazine. Once the patient is stabilized, the only definitive treatment is delivery. Since this patient is full term and has a favorable cervix, induction of labor is a reasonable approach. However, prolonged induction should be avoided, and cesarean section is indicated if the baby cannot be delivered in a reasonable period of time. Induction can be achieved with oxytocin or misoprostol. However, on the USMLE Step 3, credit will be given if you simply consult obstetrics. Antenatal corticosteroids are indicated for gestational age less than 34 weeks. Blood type should be determined for all gravid women, and RhoGAM should be administered within 72 hours of delivery if the mother is Rh negative. That's the end of the discussion for this preeclampsia case. Please take a look at our other videos as well, and thank you for joining us.